very little as a professor, it's almost laughable. Practically charity
There's
work.
11 of us in here.
What's that?
There's 11 of us in here.
Wow.
That's less than half.
Okay. So for those of you who stayed, welcome, congratulations on coming.
That's what we get.
It means that you may have actually like turned it, you may have actually finished your paper, and we'll get a decent grade on the paper that's due tonight, right?
Yep. Or we're taking a major hit by being here.
Could be.
Excuse me.
Well, here's what we'll do then. I'll give all of you 5 bonus points on exam 4.
Oh my gosh, it's Christmas.
Yes.
And for those of you who didn't stay, yay.
Yay, we already have a 5.
Yay!
So go ahead and put your name on here for me.
Oh. Ooh.
All right, so let's talk about children with neurologic or with endocrinologic
I love the
metabolic
endocrine
conditions.
system.
What's that?
I love the endocrine system.
I love the endocrine system too. It is
It's
so
so
confusing. When I was in nursing school, the 2 subjects I hated most were endocrinology and psychology. Those are the 2 subjects that I routinely failed on them. I was horrible with them. And what did I become but a midwife, which is nothing but endocrine and psych. That's all it is hormones and psychology, right? And it wasn't until, when was it? When did I read that book?
Autocorrect on my
I love
name.
that.
He's typed my name a couple times.
I think it was in grad school. I read a book about the chemistry of emotion, and it was all about psychoneuroimmunology. And all of a sudden, it started to make sense, and I started to like it. It became very interesting. That is not what this is about. This is straight up mechanical endocrinology, and it's all about a matter of what does this hormone do to that body part. Okay. In your book is a wonderful table early on in chapter 27. That's the one. What page is that? You probably should. 1062. On page 1062 is a wonderful chapter, a wonderful table. It describes the several hormones. I am not going to go over those hormones with you. We would be here for a week and not be finished with it. But understand that, remember early on we talked about hormones and the role that hormones play and how they're named? These hormones are named exactly by what they do. You know, a thyrotropin releasing hormone is a hormone that releases the thyrotropins. And what is a thyrotropin?
Something that makes
If it's
Works
tropic,
on
it does what?
making.
It acts on it, right?
Acts on the
So thyrotropic is it acts on the thyroid, right? So it releases the hormone that acts on the thyroid. So thyrotropic releasing hormone would cause the release of what hormone?
Thyroid stimulating hormone.
Thyroid stimulating hormone, which then would act upon the thyroid and would stimulate it and release T3 and T4, exactly. Okay? Corticotropin releasing hormone, again, releases corticotropins, right? Corticotropic stimulating hormone, or corticotropic hormone, would release the corticotropic stimulating hormone, just like the thyrotropic releasing hormone releases thyrotropins, right? Make sense?
Yes.
Adrenocorticotropic and all that wonderful stuff. So we're going to talk a little bit about the disorders of each of the major endocrine systems. And I'm not going to talk about all of them, just the big ones. You are going to have to know about growth hormone. That's a big one. Okay? But let's talk about hypopituitary hormones. So the hypopituitarism is, as it shows, a condition in which the pituitary gland does not act appropriately. Right? And so when you have hypopituitarism, you have a disorder of growth hormone, right? So you'll get delayed growth, less than 2 inches a year, delayed closure of the fontanelles, delayed dental eruption, greater weight to height ratio, increased abdominal truncal fat, and decreased muscle mass. Now this is interesting. Has anyone ever seen a child just before they enter puberty?
Yeah.
Yes.
Yeah.
They are chubby little buggers, aren't they? Because they've been waiting for that growth spurt to happen. And they hit puberty and all of a sudden they lose their chubbiness. Okay? Just before a child goes into a growth spurt, they get real chubby, then they grow. Because what happens is the body wants to store resources, get ready, get ready, get ready, explode. And so they store up all this stuff, all these resources, and then all of a sudden they have a major growth spurt, or they enter puberty. I'm a pretty fat person. My wife is not as fat as me, but my wife is not petite. And my children all get really fat right before puberty. Dude, my poor little 12-year-old, he weighs 144 pounds, and he's this big. Yeah, about this big. And I'm kidding. Don't hit him. But he's about that big, and he's 144 pounds. My daughter weighs 144 pounds, and she's a senior in high school. And so, they get really fat, and all of a sudden, they grow like a foot. The same thing happened to his two older brothers. That's just how it works. But anyway, so the same thing happens when you've got a growth deficiency. You're gonna start to see signs of where things are not growing like they're supposed to, and then get an abdominal fat growth. Right? So signs you might see also is that problems with the face and the growth of the face, delayed puberty, hypoglycemia, and all we can do is check them on their growth, check them on their what's the word I'm looking for, the growth charts, and then try some radiographs of the skeleton to see how they're growing. And of course, what are we looking for when we look at those radiographs of the skeleton? Not sutures. In the wrist, in the knee, in the hand. What are we looking for? Growth plates. Okay. We can also do an MRI of the brain to rule out tumor, which is a very common cause of pituitary problems. And then we can give them some medications to help them grow. Okay? Some important things for us is that our goal is to achieve normal height. So we intervene immediately. When I was growing up, and anyone who's about 40 to 50 years old will remember that there were a lot of people like Danny DeVito in the world. A lot of adults that never quite made it to 5 foot tall. They were stuck in the 4 foot range. And that was because they had pituitary issues. They had growth hormone issues very early in life. Now we screen children for that, routinely, and we watch them grow, and if they start to slip off the growth curve, we intervene immediately. So it's very rare to see someone who doesn't have dwarfism who would have a growth issue. This disease, of course, is entirely different from dwarfism. This is a pituitary issue, and we can fix that with medications. Dwarfism is a genetic issue, and we can't fix genetics yet. Okay? But the goal is to reach normal height. And the other one is to help them accept the fact that they might not be the same as everybody else. Okay, we want to avoid body image disorders. Okay. Now, the opposite, hyperpituitary function, which will do the exact opposite of hypopituitary function, right? It's going to delay puberty. It's going to cause precocious puberty. It's going to cause, breast development and hair growth and oily skin in children who shouldn't be having it yet, 7, 8, 9 years old, and they look like a 12-year-old. Last month I did a Boy Scout fair, and I taught first aid for a merit badge fair, and one of the kids had a little mustache on his face and a little hair on his chin, and I was like, isn't that cute? This 15-year-old trying to grow peach bars, ha ha ha. He was 7th grade.
What?
Yes, he was 11 years old, and he already had facial hair.
There's a guy I went to elementary school, was 3rd grade, and he had a mustache.
Yeah, that would be precocious puberty. Okay, that might be a pituitary function problem.
But he's not abnormally tall though. He's like a tall dude, but he's not like a giant.
Well, it's kind of tough to say when you're in 3rd grade who was a giant, who
No, I'm
wasn't.
talking about now. I know him now.
Oh, you know him now?
Yeah,
Maybe it was subclinical, or maybe it was fixed, and they didn't bother to tell anyone. But it's when you see facial hair before the age of 9, penile growth, increased masculinity, testicular involvement, those things, you see signs of puberty in a child who should be nowhere near puberty yet, you got issues, right? Same thing with girls. Menarche before the age of 8, cysts on the ovaries, pubic hair where it doesn't belong, it doesn't belong on anyone at 8 years old. Active body odor.
Pubic hair where it doesn't belong.
Yeah, pubic hair. It never belongs in an 8-year-old. How odd, the idea of an 8-year-old with pubic hair. But that's because there's something wrong with their pituitary gland, right? Giantism, uncontrolled hypersecretion of growth hormone, creates people who are enormous, okay, like Andre the Giant. They have rapid growth during childhood. They have swelling of the soft tissue, skin tags, muscle weakness, skin changes. They mature very quickly, but when you've got growth hormone issues, it's a skeletal development instead of a endocrine organ development problem.
Is this the same thing as like Marfan's?
It's very similar to Marfan syndrome, but Marfan syndrome is not an endocrine disorder. It's a chromosomal disorder. And Marfan syndrome comes along a lot with a lot of what's the word I'm looking for? Connective tissue disorders. Like they have aortic problems, they have joint tissue injuries.
And aren't there long bones, like super
Yeah,
long?
yeah, they have excessive long bone growth, yeah. And I think Andre the Giant might have been a Marfan kind of guy, because he died early.
They think that Abraham Lincoln had Marfan's.
Could have, but he lived an awful long life for Marfan syndrome.
I'm just saying.
I'm with you.
How tall he was?
I have no idea.
He was 6'6" in a day when everyone around him was 5'2".
Wow.
Yeah, he was enormous. But what I met somebody actually I met him at the Greek Fest. Dr. Barry brought him in, a friend of hers. He's 7'2". Her
Not
boyfriend.
friend. Friend.
7'2". Hey, I'm not going to talk about anyone's personal life. I don't know who the guy was. All I knew was he was humongous.
It's Franklin.
It's Franklin.
Is it Franklin?
It's Franklin.
Apparently he's a
Yeah.
doctor here in town. I don't
He
know who he
owns
is.
Village Green.
What's Village Green?
It's a rehab center.
Oh, nice.
Mm-hmm.
That'd be nice. I'd like that.
He got that
You got that. Got them Benjis.
Wow.
Now let's talk about the posterior pituitary gland. Diabetes insipidus, the same in children as it is in grown-ups, right? It's a deficiency of the production of ADH or response to ADH, and it causes, now the interesting thing is what it causes. We don't talk about poor feeding and failure to thrive or fussiness in adults, right? And that's because adults express themselves verbally, where infants can only do this. And so, poor feeding, failure to thrive, and fussiness, you're going to see that a lot. That's the way children respond to just about everything in the toddler years and below. But saturated diapers with signs of dehydration is an interesting conflict. Like a baby who doesn't cry, who cries but there's no tears, and yet they're continuing to saturate diapers. They also might have sunken fontanelles and maybe even a sunken face where they look dehydrated, and yet they're showing obvious signs of hydration. Okay? And why is that, of course? Because these kids who don't have antidiuretic hormone or don't respond to antidiuretic hormone are going to be peeing like crazy and getting rid of every bit of water they have. You don't ever want them to run out of urine. It's not like us. We get dehydrated, we stop making urine. They haven't that protective mechanism. Okay? Why would they have constipation?
Because there's no water.
Because there's no water in the stool, exactly. All the water is being passed out through the kidneys, right? So no water in the stool means it's not going to move. We rely on the water to lubricate the stool. That's why drinking water is such a wonderful way of fixing constipation. We need a little extra water in our stool. Okay? Syndrome of inappropriate antidiuretic hormone. This is one of those things like placenta previa is painless bleeding and placental abruption is painful bleeding that you just see over and over again. I think just because it's cool to say syndrome of inappropriate antidiuretic hormone. But this is an excessive secretion of antidiuretic hormone. So these kids are going to stop making urine and they're going to accumulate water all over the place, right? So they'll get nausea, vomiting, seizures, and headaches. Why would they get seizures and headaches? Yeah, accumulation of fluid on the brain, cerebral edema, right? And then, of course, all those things that go along with that. Personality changes, hallucinations, irritability, all that goes along with the intracranial pressure increases. Increase in blood pressure because they're holding water. Weight gain because they're holding water. Fluid and electrolyte imbalance because they're holding water. All those things kind of make sense, right?
So the difference between this and diabetes diabetes insipidus is getting rid of everything,
Exactly.
whereas this is taking in everything.
Exactly. Diabetes insipidus is the opposite of this, okay? And it's inappropriate, inappropriate antidiuretic hormone. See, I would have named it as like insufficient antidiuretic hormone to make it sense, right? But just inappropriate, I don't know, too much, not enough,
It's
I don't know.
inappropriate.
It's inappropriate, but it really is, that it's excessive, they have too much. It's not appropriate. Knock it off, that's not appropriate, right?
Inappropriate.
There you go. All right. Let's talk about metabolic conditions, specifically diabetes. Not much different for children than it is for adults in how it comes and why it comes and that sort of stuff. The difference is more the mind games you have to play with children to teach them about diabetes. Because, you know, tell a kid, nope, you can't eat candy anymore. Sorry, no Halloween for you, buddy.
That's terrible.
Isn't that awful? It's very awful. So they're kind of different. So type 1 diabetes, okay, you should all know this from your Adult Health 1 class. Type 1 diabetes is an autoimmune disease in the child, or it's a genetic predisposition to diabetes. It's a classic organ failure type disease. Like heart failure, like kidney failure, like anything else, it's pancreas failure for one reason or another. And you have the same things in grown-ups that you have in children: polydyspnea, polyuria, polyphagia. But one thing that I always find striking in children who are diagnosed with type 1 diabetes is they eat like crazy and they get skinnier and skinnier and skinnier, despite the fact that they're eating really well. And it's because their body can't use the glucose in the food, and so they just continue to go downhill because they can't use it. Okay. Anytime you have a child who wets the bed after 5, they have to be screened for diabetes. Okay, because nocturia is very common in diabetes, and so if you got if you know a bedwetter, one of the things you need to screen them for is that diabetes. Okay, but of course they also could eventually become ketoacidotic, and then they're going to get that fun abdominal pain, nausea, vomiting, fruity smelling breath. We're going to move on because we've already seen this. And diagnosis is based on elevated postprandial glucose, just like in grown-ups. Okay? So, just like in grown-ups, we're going to obtain glycemic control. We're going to minimize complications from our diabetes. And the big thing we have to do, though, is to teach the child that this is a lifelong, never-changing, you got to fix this or you'll die kind of disease. Okay? I've always felt horrible for people with diabetes, with juvenile onset diabetes, because you can cure cancer, okay? You can cure leukemia, but you can't cure diabetes. All you can do is control it, and sooner or later, the long-term effects of diabetes are going to strike, right? Now, if you're 40 and you get diabetes because you're fat, no big deal. You got 30, 40 good years left, it's okay. But you're 10 and you get diabetes, 30, 40 good years means you might become a grandparent, okay? That's about all you can expect. So now we're getting better and better and better. We've got these insulin pumps. We're doing really good at controlling diabetes. But the problem with children is it's impossible for an 8-year-old to think, what am I going to be like when I'm 40? You can't tell an 8-year-old you're going to lose a toe. What do they know? They don't understand it. They don't have the abstract reasoning that they need. So all of your goals have to be very short, very acute, very immediate. Okay, explaining good sugar management in a very, very simplistic way, and then relying an awful lot on the parents to help the child manage blood sugars. Okay, those children, by the way, tend to really act out when they become teenagers, and when they start to become rebellious. I don't want to be this anymore. I'm going to be different. I'm going to eat my Snickers bar if I want to. And then they end up running themselves into trouble because the rebelliousness of teenage years doesn't play well with chronic illness, especially chronic illness that you can't absolutely feel, If you've got congestive heart failure and you're 16, well, there's not much you can do to rebel, right? Don't take your meds, you end up unconscious and wind up in the hospital. But the diabetics, they can rebel for a long time before they end up being caught.
It's like Brett Markle.
Like which?
It's like Bret Michaels.
Bret Michaels? Oh, yeah, because he was diabetic, right?
Yeah.
Is he dead yet?
No, he's not dead yet. He's still going strong.
Going strong. Didn't he have a stroke a year or two ago?
Yeah, something like that.
Yeah, but he's still performing.
Is he really?
Yeah.
Talk about past your prime. Was he poisoned or something? Who's Bret Michaels? Yeah. 80s hairband. My God.
And then he had that super fun VH1 show at one point.
Yeah.
Rock of Love with Bret Michaels.
Oh.
Yeah.
If you say so.
He did have an episode on that show, I do remember that, where like his insulin, something happened.
Uh,
He calls it the diabetes.
the diabetes. I like that guy with the Lauren Michaels, who does the commercial for diabetes testing supply. That old man, he's funny.
That's what my
Anyway,
dad used.
so let's talk about type 2 diabetes. Type 2 diabetes used to not be involved with children at all, but wonderful childhood obesity means that we're seeing it more and more and more. It used to be type 2 diabetes was the adult onset diabetes. Not anymore, okay? Now we're seeing it in younger and younger children, just like we're seeing high blood pressure in younger and younger children. We usually don't notice that they're diabetic until someone says, wow, you're awful fat, we should test that. And then they catch
I'm sure
it.
that's exactly what they say.
What's that?
I'm sure that's exactly what they say.
Oh, I'm sure that's how they say it, right? Yeah.
Wow, you're fat, let's get you.
Wow, you're fat. Let's see you. Let's get you up here and give you a fasting glucose. But that's how it's described. And it's always interesting from a provider's perspective when you get to be the one that finds something as obvious as type 2 diabetes. Somebody who's morbidly obese and they're like, no, I'm perfectly healthy. Really? When was the last time we checked your A1C? What's an A1C? Come on over here, fat little buddy. Let's check that A1C. And sure enough, it comes back high, right? It's always interesting because the problem with diabetes is you can't feel it. It's like blood pressure. You can't feel it. It's insidious. If they actually had numbness or tingling or blurred vision or anything like that, that's late in the disease process. You know, that's neurologic injury caused by the diabetes. So most of the times you don't get any symptoms at all. You just have risk factors and you screen for it and you end up finding it. Okay. But these symptoms are all signs of high blood sugar, right? Polyuria, polydyspnea, enuresis, yeast infections, whole body itching, all that wonderful stuff. Okay. And the diagnosis is made as such. So criteria for screening is BMI greater than the 85th percentile, weight greater than the 86th percentile, or greater than 120% of the ideal body weight, plus 2 of the following risk factors: family history of diabetes or race and ethnicity.
So it literally is, hey, you're fat.
Hey, you're fat and you have risk factors, yeah, exactly. You know, I call them like I see them, right? Now, let's get into the heart. I absolutely love the heart. And this is where having that concrete understanding of fetal circulation is so important. Because because you guys had memorized the ductus venosus, the ductus arteriosus, the way blood flows in and out of the heart and how it mixes oxygenated with deoxygenated blood, you're going to understand heart defects in children very, very well. Okay, because most of the heart defects that you're going to find in children are errors of that transition to extrauterine life. Okay, or they're errors that happened, or they're defects that happen that were compensated until they start to make that transition to extrauterine life. Okay, and so that's what we're going to talk about now. So it's important to remember about the heart that you have 2 atria and 2 ventricles, that the atria are reservoirs, they simply hold blood, and it's the ventricles that push the blood out. Okay, and when the ventricles push the blood out, they create a vacuum that pulls that reservoir blood from the atria into the ventricles, right? So blood flows into the atria and sits there, and then the ventricles squeeze it out and create a vacuum, go suck more blood into them and push it out again. Okay. And so the right side receives the deoxygenated blood and the left side receives the oxygenated blood. That the blood flows in from the vein, in from the venous system into the right atrium, down into the right ventricle, from the right ventricle out into the lungs where it receives its oxygenation, then back in through the pulmonary vein, back into the pulmonary vein to the left atrium, then into the left ventricle and out through the aorta, right? Okay. That's important stuff to understand, because if your blood vessels are connected wrong and you're sending blood from the left ventricle to the lungs, you got problems, right? If they're twisted, or if there's holes, or they're leaking blood from the left side to the right side, you're going to have problems because you're not going to have well oxygenated, separated blood, right? You're going to have it blending, and that's where babies get into trouble. Okay? Wonderful valves, they always confuse me. Okay, the tricuspid valve and the mitral valve and the aortic valve. I used to have a real clever way of remembering this. How was it? How does it? Oh, it'll come to me. It'll come to me later.
That's right. All people everywhere take meds.
All people everywhere take meds. What's that?
That's the position for your
Well, go for it. Tell
stethoscope.
me about it.
Oh, she started it.
No,
Oh,
that's not
that's-
the order of the valves, though.
No, it's not the order of the valves, but that's the position for your stethoscope. So you
Okay,
listen-
what is A?
So aortic, you listen over here.
Uh-huh.
All people, everywhere is Erb's point. Take is the tricuspid, and meds or is the mitral.
Okay, and so where is the tricuspid valve?
The tricuspid valve is in the lungs.
On the left side?
It's not the
On the right
pulmonic.
side.
Okay. Is it in the right side or the left side?
I thought it was between the left, or the right atria and ventricle.
That's good.
Hold on. There's a picture.
Google, you got a book?
I didn't bring that baby.
Google her. No, I think, wait.
I
Yeah,
bring
no,
mine.
the mitral valve is on the left side. So this side. This, the tricuspid.
The mitral valve is on the left side and the
This
tricuspid
is.
valve is on the right
This
side?
yes.
Okay.
Right. And then
And then, of course, we already talked about the vena cava carries blood to the right atrium. Pulmonary artery carries blood from the heart to the lungs. And of course, is the blood in the pulmonary artery oxygenated?
No?
No, it's not. And is the blood in the pulmonary vein oxygenated?
Yes.
Yes, it is. So it's normally, arterial arteries carry oxygenated blood, but not this one. Because what is the definition of a vein?
returning blood to the heart.
A vessel that returns blood toward the heart,
Yeah.
exactly. And an artery pushes blood away from the heart, right? And so that's why the pulmonary vein carries blood from the lungs to the heart, and the pulmonary artery carries blood from the heart to the lungs. I'm sorry, the other way around. You know what I mean. So pulmonary artery carries blood from the right ventricle to the lungs, okay? Deoxygenated blood in an artery. And the pulmonary vein brings the oxygenated blood back from the lungs into the left atrium, okay? And of course the aorta is a gigantic lead pipe that takes blood from the heart and carries it to the entire body. So here, normal blood flow. Okay? What I think is interesting is they have that little, see that's not quite perfect? I wish I had something to point with.
Stay on the table.
Stand on a table. That might not hold 250 pounds. All right. So terms you need to understand in order to understand heart disease in children, or in anybody, that cardiac output is the amount of blood discharged each minute from the right or left ventricle. That stroke volume is the amount of blood ejected by the left ventricle with each heartbeat, and that there's a difference, right? The preload, the equivalent of the venous blood return to the atria from the body and end diastolic volume of the heart. Afterload is the aortic impedance or wall stress, so that's the pressure exerted that it takes to get the blood out of the heart. Contractility is the force extended or exerted at ejection, taking into account end diastolic volume and wall stress. Okay. Now let's talk about congestive heart failure. The reason we start with congestive heart failure is that an awful lot of these diseases are going to end up causing congestive heart failure. So understanding congestive heart failure, especially in children, makes it easy. That makes all the heart defects purely structural. Okay, where you just have to remember that transposition of the great vessels means that the vessels are transposed. Done. right? Okay, you know what, it's 2 o'clock, you guys ready for a break?
Yes.
This is a good place to stop for a break, because it's gonna get kind of detailed for a minute.
Right,
Okay, ready, break.
So we can take a nap.
A nap?
Yeah.
Good luck with that.
I'm gonna go home, I'm gonna nap, then I'm gonna shower, then I'm gonna eat, and then I'm going to eat.
So your paper's done, is it?
It will be done.
It
It
will be
is done, I'm just nervous and trying to put you.
Oh, I got you.
She still hasn't sent out the printed.
She better send it out before freaking 9 o'clock.
Well, I asked her whenever we were in.
By the way, Hannah, did you get my response to your thing?
Yes, after class. Corrections.
Was it helpful at all?
Yeah, she read over it this morning too.
Like you.
She didn't really like us, so that's gonna be my other issue. She'd be like, listen to what you did.
Same.
Well, yeah, I mean, it's an interesting problem that you have, because your bill isn't much of a bill at all. All your bill is saying is, should we ask the question?
Right.
And it's not saying anything about what the question is going to end up being, or what they're gonna study. It's just, should we ask? Yeah, we may want to ask.
Let's do the research.
14.7. 14 point? That Starbucks drink was 14.7.
Shit, oh my gosh. That's half of my daily points, basically.
Well, that's what you get for drinking ice cream in a cup.
Hey, I deserve that ice cream in a cup. I haven't been eating lately
It's about human trafficking.
because of my medicine, so something.
Oh, absolutely.
No,
My
like,
wife, she's so sweet, she bought me eggnog flavored coffee creamer. It's awful, but I'll drink it because she bought it for me.
I just wish you'd send the turn it in thing so I can turn it in. It's hard on everybody. Specifically, physicians, physicians, and physicians compare modern You okay? You leaving?
Yeah,
Why are you leaving?
because my freaking husband's left me hanging.
Oh, I'm sorry, I didn't mean to.
Kick his ass.
Yeah, you want me to cut him?
I know.
Yeah, the recording off, say what you need to say, girl.
Look, bury him in the front yard. They always do. Call me at freaking 2 o'clock.
Then, can't live with him?
I was just about to say that.
At
About
this
it.
couch. That's it, exactly.
That's it, right there.
Can't live with them.
Pretty much the extent, right there. Can't live with him. You can live without him. I'm sorry. Thanksgiving breakfast you started. And until you turn your paper in.
Yay.
Yay.
And at least you were here long enough to get 5
No.
I know, you're officially 5 on that test.
Shoot.
You're halfway through your test.
I've been thinking this was like all.
You took it off the internet or something?
Just get your
You have to.
Yeah. Everything okay? Yes.
His house doesn't.
I just need to leave it.
Can I play my pitch for next time? So I'm gonna let you look at it.
You know what you need to do then?
No, I don't. They.
So now you got it. They must have called us last minute. But everybody else, even he, I told him, let them know. And he had to go. Cause he was supposed to be off at 11. in tonight at 7 and work the overnight shift for that Thanksgiving week.
But he won't speak up and say, I need to go to my son's.
Okay. Oh, he gonna get beat, for real. Kidding, just kidding, just kidding. All right, ladies, see you next week.
Bye, happy Thanksgiving.
Thanksgiving. I'll be texting you.
What's the sauce?
It's from His Perfect too.
No.
Throw your freaking
It's too early for Christmas. Oh my god. I just wanted to play
2 more days, no, 3 more
Oh my
days
God.
after Thanksgiving. Can we can celebrate Christmas.
And you can hang up your lights and
It's
everything.
too early.
Mine are going up Friday.
Okay.
Right, that's what a lot of people do.
Well, okay, mine are going up Friday if my husband gets off his lazy ass and goes and gets them.
You gotta get new ones?
No, because he's gotta get them out of the shed and out of the attic, and he won't let me do it. Like, if I go get a ladder, he's like, no, I'll do it, and then he won't do it.
Dude, that sounds like my dad.
Gotcha.
I've been living in this house for almost exactly 3 years. In March will
And
be
then
3
there were
years.
10.
I've asked
Yo.
him every,
5 more points.
I asked him every year, hey, can you hang up the lights for me since you won't let me do it? He won't do it. He won't hang up the lights. Because he doesn't want to. Because he's anti-decorating.
My dad is too. But my mom.
Well, look, when a man says he'll do something, he'll do it. You don't need to bug him every 6 months.
Right?
Don't
I
worry,
laid out
we'll
the
get
game
to it.
plan for this weekend already 2 weeks ago. I was like, okay, I'm
This
going.
weekend, it's too early to decorate. I'll be right back.
Lock him out, yeah.
I wish I could.
Okay, let's do it. Let's do it.
You can't lock the door.
Barricade it.
He's not bored.
Do it. For real. Someone.
Did you get my email?
Me? I haven't checked my email.
I need a charge.
Yeah.
All right, everyone plug in.
Plug in.
You know, it's an interesting thing.
Yeah.
I listen to BBC all the time. I really like the BBC because it gets rid of all the American biases, and it is so global. And it really helps you understand that we got it pretty dang good in this country. You know, oh, we bitch and whine and moan, but we got it really good. So anyway, so I listen to BBC all the time, and one of the things I thought was interesting was they're tracking this family who's trying to move from somewhere in the Middle East to somewhere in Europe, and so every couple of days the family will get a hold of this reporter, and the reporter will fly to wherever they are and interview them again, and then leave. You know, they're not gonna make the migrant journey with them. It's hard and dangerous and whatever. And so, you know, like they finally made it to Greece after several attempts, and they called and said, "Hey, we're in Greece," and she came and interviewed them and then left. And what was interesting is one of the things they were complaining about was on the ferry to Greece, and when they got to Greece, people were fighting over plugs so they could charge their cell phones. Like, seriously? Refugees with cell phones? What the?
Hey, why not?
It's the modern world, I get it, but really? Refugees with cell phones? You got it pretty good when you can afford international rates, right?
Wow.
It was a mind blower to me. I couldn't. I'm still struggling to wrap my head around it.
They're so cheap. Cell phones are so cheap.
Yeah.
They probably have some kind
If you say so.
No, they are. Like,
Yeah,
Korea and all that. Because that's where they're made. A lot of them.
And the repair is so cheap, so they don't buy it.
I told you about my day on Friday, didn't I, Professor Johnson?
You did.
Okay, good. I just wanted to make sure.
That you had an extremely busy
I
day.
did.
All right. Now I got a laser pointer,
Oh, yeah.
so I don't have to stand up on the chair.
Oh man, that's funny.
I know, that's like the best part, right? Watch the old man break his neck.
Well, the good news for you, there are 1, 2, 3, 4, 5, 6, 7, 8 currently in this room, future nurses that probably could take care of you.
Nice.
Probably.
We've been,
Nice.
I probably won't be able to do anything except for stabilize your neck, that's about it.
we're like,
Call Cavaness! I'll make sure I dial 911 real quick,
Yeah.
but I got my phone ready.
Someone call IXII. That cracked me up. Okay.
from Hercules.
Yep. All right. So let's move on. So congenital heart failure or congestive heart failure. So like I said, understanding congestive heart failure gets you to the nursing care associated with most of these heart defects. It's characterized by an inability of the cardiac muscle to move blood forward, so blood backs up, just like it does in grown-ups. Okay? It varies with the age and location of the congestive fluid. So obviously, congestive fluid that is, in the lungs is going to cause pulmonary edema. Congestive fluid in the legs is going to cause pulmonary edema. I mean, it's going to cause pedal edema, right? So what's interesting is, again, what do we see for children? In infants, you see congestive heart failure as the same problem as you see with all the other ones. Poor feeding, poor growth, irritability. They do start to have some shortness of breath and sweating because they have this excess fluid that they're trying to get rid of. And then it can eventually develop to enlarged liver and edema. What's also very interesting is notice that babies have different sites for edema, okay? In a child with congestive heart failure, you see puffy eyelids and swelling of the hands and a bulging fontanelle. And you don't really see that too much in adults. Sure, they can have some hand and feet swelling, but they don't get the puffy eyelids and bulging fontanelles, of course, because they don't have fontanelles anymore. But it's just important to understand that that's a different finding for babies and toddlers than it is for adults. In older children, you can get poor growth. Why would you get poor growth?
Because there's no circulation.
There's no circulation, right? No circulation means no oxygenation. No oxygenation means no growth. Okay. Also poor glucose distribution, right? Shortness of breath and exercise intolerance. That's a big one. Exercise intolerance. When you're working with children and they say, my kid is tired all the time, he can't go out and play, or he gets tired immediately as soon as he goes out and plays, you had better be ruling out congestive heart failure, and you'd better be thinking of that pretty high on your assessment list when you're answering these questions next week, right?
Yeah.
You rarely see ascites in children, but you might see it more in teenagers as they get older. Okay? Diagnosis is made through physical exam. And this is cool. Who can tell me what beta natriuretic peptide is? You guys heard that phrase before?
It's the BNP.
What's a BNP?
Isn't that if you have
It measures heart failure. That's something totally new. I'd never heard of that before.
Thank you, Mary.
Gotta love it.
For Russian.
Yep. What's that? Yep. I had to look that one up. I was like, what on earth is a beta natriuretic peptide? That's what you get for not taking care of sick people. That's why you careful. Chest x-rays, looking for the size of the heart and ruling out pulmonary edema. Exercise tests where you put them up on the treadmill and make them go. MRIs, echocardiograms. Echocardiograms are particularly useful at assessing, because what can you find when you use an echocardiogram looking at children's hearts?
You can do the cardiac output.
You can do the cardiac output, you certainly can. Because when you're listening to a heart, you might hear murmurs, right? And the murmurs might be useful. But how wonderful is it to be able to watch the heart beat and go, oh, look, I've got blood flowing in the wrong direction. Or I got blood crossing this valve. It's not supposed to be crossing this valve. You can pick up all your pulmonic regurgitation. You can pick up you can see the coarction of the aorta. Echocardiograms are particularly useful in the diagnosis of heart defects in children. Okay? And management depends on what's causing the problem, right? And you guys know all this because you get all this in Adult Health 1. Not terribly different in grown-ups from children. Okay? Now back to the education piece. It's a big piece here. Children still deserve to have their childhood, okay? And heart failure is particularly taxing on children because they don't understand it. All they know is that I can't play like I want to. I have to eat the special diet. I can't eat what I'm supposed to eat. I can't eat what all my friends are eating, that kind of stuff. And so we're going to teach them how to monitor their vital signs, how to recognize signs of problems, how to use their medications, and what their medications are going to teach them. And that's pretty important, especially for the parents, because like I said, a 6-year-old or a 4-year-old is not going to understand the side effects of their medication, okay? But working in conjunction with parents, it's too bad that, what's her name? Jennifer? Not Jennifer. She sits over there. Jillian. Too bad Jillian's not here, because she used a wonderful theorist about how parents and healthcare providers work with children in conjunction to help children to get better. I'm blanking on the name of it now. I would ask her all about it, to tell you guys all about it, but she's not here, so she can tell you guys about it later. You can mug her in the hallways sometime and get her to tell you all about it. Okay? That theory, I think, is particularly useful when you're taking care of pediatrics. Okay? Let's talk about, let's see what else is important. Teaching about exercise for the kid, about how to make their muscle, how to exercise, how to make play part of exercise, getting kids into rehab to help the muscles, to muscle strengthen, can also be very, very useful, okay? Let's see here. Now, congenital heart disease, exactly like it sounds. What is congenital heart disease but a?
Congenital defect?
Okay, a defect that you're born with, right? A defect of the heart that you're born with. Oftentimes these are detected by either the kid turns blue when he's not supposed to, the kid has exercise intolerance, or we hear murmurs in the heart that we shouldn't be hearing. Okay? Now there are a couple of normal murmurs that you're going to hear in the newborn nursery, right? It's pretty common the first day of life to hear a little murmur once in a while in your babies, and first or second day of life, and what are those?
It's from where the foramen valley may have.
Sure.
shut
Closing
down.
of the foramen valley or closing of the ductus arteriosus is going to cause a little transitional murmur, and we'll hear it once in a while. They're kind of interesting. It's like, oh, that's neat, and then you just move on. But when you've got a 3-month-old, 4-month-old with a murmur, there needs to be evaluated real closely. Obviously, cyanosis is a big, big baddie. It means that the kid is not getting oxygen, and there aren't too many good reasons for a kid not to get oxygen. Anytime a kid is turning blue, he probably needs to have that looked at. Okay? Polycythemia, excessive red blood cell production. Why would a kid who has a congenital heart disease get polycythemia?
But I'm sorry, Kelly just blocked out what you said.
Okay. Why would a kid with congenital heart disease develop polycythemia? What's the physiology behind that?
Like overcompensation?
Overcompensating for what?
Blood,
Not blood loss.
production.
No. What does blood do?
Circulate.
Provides oxygen.
Provides oxygen, right? So a kid who's cyanotic is going to produce more blood cells in order to carry what little oxygen he can get to the rest of his body. Same thing with smokers, same thing with people who live in high altitudes. They develop polycythemia too, in order to compensate for the fact that they're hypoxic. So polycythemia is a response to hypoxia. Anytime you have chronic hypoxia, you're going to end up with polycythemia. It's usually fairly mild, just a point or two outside of normal, but it can lead to what's called hyperviscosity syndrome. And hyperviscosity syndrome is just too much blood and not enough serum. And they form clots, and they can have strokes and all kinds of wonderful badness. So understand that children with hypoxia, with chronic hypoxia, are going to get polycythemic, and you're going to need to respond to it. Okay? You diagnose polycythemia, of course, through a CBC, and you treat it. What they actually will do is take blood away and replace it with fluids. Like 1 liter of blood out, and well, not a liter, but like a cup of blood out and a cup of D5LR or whatever back in, or a cup of serum replaced. And they do a 1-for-1 transfusion. You can also detect your congenital heart diseases with echocardiograms and a cardiac catheterization to get a direct measure. I think that my kid would have to be really, really sick before I let him do a cardiac cath on my 3-year-old. I'd be pretty happy with the echo, right? Nursing care is standard supportive care, maintaining the oxygen and nutritional status, providing emotional support, and helping with the medical management to reduce the preload, to increase the afterload, and get the contractile function up as well as we can, right? Okay. Then, of course, there's always the idea that these kids with congenital heart defects are going to need heart surgery in order to repair these defects. So we have our preoperative and postoperative care, taking a thorough history, getting the consent form signed for whatever reason, continues to be a popular answer on tests. And if there's nothing more important on your list, getting the consent form becomes your priority, right? So, making sure the kid's not bleeding to death is pretty good. Making sure the kid's not, that he's got decent oxygen saturation is pretty good. But if those things aren't there, and it's like teach the family something or get a consent form, which is your priority? Getting the consent form, right? So this test bank loves to ask questions about consent forms. So when you see it and there's nothing else more important, consent forms become your priority. And that's a big thing I think people struggle with. It's not black and white. The consent form is not the priority when there's a life-threatening condition going on, right? And then postoperative care. Always talks about what the admission to the intensive care unit is like. Because what's the PICU like to a parent? Super scary, right? My kid's going to have tubes coming all in and out of him. He's going to be on monitor. He's going to be sedated. He might be on a ventilator. It's super, super scary. These kids don't survive surgery, and they don't survive the post-op recovery very well sometimes, and that's super scary for grown-ups. There is no such thing as minor surgery on your children. Okay? Every surgery, even tonsillectomies and ear tubes, are scary for parents. But heart surgery is particularly scary. So preparing the parent for it is as important and more important than preparing the child. Okay? Obviously, parents need to learn CPR. I think if you've got a baby with a heart defect, that seems to be a no-brainer, right? All right, let's move on. So things to teach parents about for kids who have who need pulse oxes at home: how to respond to shortness of breath, or how to recognize problems with the pulse ox, how to recognize other things besides the decreased pulse ox that he's going to show, like a kid with a decreased appetite and shortness of breath may have a low pulse ox. I got to tell you a funny story. Elizabeth was a home health nurse for a while when she got out of the Army, and she was, because she's a pediatrics nurse, she was always taking care of these kids with congenital difficulties of one time or another. And she had this little girl who she took care of all the time. She loved this little girl. It was so wonderful. The kid was really sick, had like a trach at home and that kind of thing. And my wife got a call that said, you've got to come quick. She keeps turning blue. Her pulse ox is really low. And so she said, all right, no problem. I'll be there in just a few minutes. And, she could get there before the ambulance could get there. So she got there, right away, and she started assessing everything. And she couldn't figure out what was wrong. She checked the line, she checked the trach, she suctioned. She did all the things that should improve the oxygenation, and it didn't. But the kid looked great, had wonderful clear lungs. There was nothing really wrong with the kid, but just continued to desaturate over and over and over again. So, she called the ambulance, said, I need you to come, we need to transport to the hospital. And then she continued to go back to troubleshooting her problem. And she thought, okay, I've checked everything and I can't find anything wrong. Let me check the machine again. So she went to the machine, and she had checked the machine once before, and it was all looking good. She said, let's check the tubing. So she took the oxygen tubing, and she went inch by inch along the oxygen tubing until she found a spot where the puppy had chewed a hole in the kid's oxygen tubing. And as soon as you replaced the kid's oxygen tubing, her pulse ox was right back up, nice and high. And she's like, okay, well, I guess we don't have to transport anymore. And it's like, well, what do you know? That would have felt pretty silly. Get into the hospital, and they're like, what? There's nothing wrong with her. And it's because the oxygen, just had a hole in the oxygen tubing. I assume the dog got a spanking. You're trying to kill the kid. Right? All right, let's see, more about education. Now, so we're talking about post-operative care, and these are all pretty straightforward stuff, right? Important stuff, this is pretty neat. Cradling the infant or the child, don't lift him from under the arms. Duh. I would say that if I had chest surgery and you just split my ribs open and you grabbed me by the chest to pick me up, I'd probably be unhappy about that.
Just maybe.
Just a little. Okay? Now, ventricular septal defect. What is a ventricular septal defect?
The septum is not fully,
Aha! The septum is defective. Right? What septum?
The one that separates the ventricles.
The hole between, exactly. So this is a hole, a congenital hole between the left and right ventricles, right? And if you've got a hole between the left and right ventricles, what problem do you have?
You're mixing oxygenated blood with deoxygenated.
You're mixing oxygenated blood with deoxygenated blood, right? You're also going to have a problem where the left ventricle contracts and half the blood squirts into the right ventricle, right? So you're going to get hypoxia because you're mixing your oxygenated with deoxygenated blood, and you're going to get hypoxia because you can't get any blood volume out of the heart. And you're going to end up with congestive heart failure because it's all going to back up in the right side and then get back into the lungs and all that wonderful stuff, right? So they tend to be fairly asymptomatic unless it's really large. You get a left to right shunt, and then you'll start to get problems. The same problems you always get: shortness of breath, feeding difficulties, poor growth, easy fatigability, and recurrent pulmonary infections, okay? And I would think that all of those are pretty straightforward, like, duh, right? Good. You might hear a murmur as it flushes back and forth between the two ventricles, and diagnosis is maybe we hear a murmur, and then we do some tests. Chest x-ray, EKG, echocardiogram, all the wonderful stuff. You're going to see that over and over and over again. Murmur, chest x-ray, EKG, echocardiogram, MRI, over and over and over again. Okay? Patent ductus arteriosus, which is the simplest and perhaps the most common congenital heart defect, and it is exactly what it sounds like. And what is that?
Ductus arteriosus.
It doesn't close, right? And so when you've got this patent ductus arteriosus, you have oxygenated blood that is... you have a connection. Well, let me ask you, what is the ductus arteriosus?
It is where?
does the newborn.
The aorta and the.
Yes.
Okay, so it's a piece of fetal circulation,
Right.
Yeah.
and it's a duct between which two vessels?
The aorta and the aorta.
No, I thought it was the.
The aorta and the
The pulmonary.
The left ventricle.
pulmonary,
The left.
The pulmonary artery.
pulmonary artery.
Same thing.
Okay, so it is a connection between the aorta and the pulmonary artery. Remembering in fetal life, blood didn't have to go to the lungs, so it left the right atrium, the left ventricle and the right ventricle, and both of them ended up going through the aorta, right? So blood is bypassing the lungs, and blood is going directly to the body. And so, what do you think the downstream effects are of having a patent ductus arteriosus? What is maybe not getting? Where is blood not going? Not going where?
To the lungs.
Not going to the lungs, okay? And if blood's not going to the lungs, where is it not coming back from?
The lungs.
The lungs, okay? And if blood's not coming back from the lungs, what do we got?
Unoxygenated blood.
Exactly, hypoxia, unoxygenated blood, right? So we have this blending where both the left ventricle and the right ventricle are putting blood in the aorta instead of putting blood to the lungs. And so no blood, or diminished blood flow to the lungs and diminished blood flow back from the lungs is a real hypoxic problem, right? So you'll definitely hear a murmur, and the murmur tends to be very mechanical sounding. It's machine-like as it rushes back and forth, like that, okay? These kids get frequent colds, susceptibility to RSV, fatigue, poor feeding, poor growth, and blood pressure is very wide between the systolic and the diastolic, okay? Because they've got a pressure leak, okay? So we get the murmur, we take some pictures, we see an enlarged heart because the heart's working harder to pump blood because it keeps leaking. We're evidence of excessive blood flow to the lungs. That's interesting. I'd have thought it was the other way around. Anyone want to answer that one? Why would we have excessive blood flow to the lungs?
Because the blood's coming from the aorta. There'll be higher pressure there.
Coming back from the ventricle into the lungs? I guess it could be.
Because the aorta's at a higher pressure than the pulmonary artery,
Sure, sure.
so it would go from high to low.
go with that.
That's what my cardiologist told me, so
Well, there you go. What, do you have a PDA?
they thought I did, they're still not sure. They can't see it.
Now, obstructive lesions. So the first ones were hypoxic lesions. Now we have obstructive or malformations. Now we have pulmonary stenosis, an obstructive lesion. What is a pulmonary stenosis?
A narrowing.
It's a stenosis in the pulmonary artery, right? A narrowing of the pulmonary artery. So if you have a narrowing of the pulmonary artery, what does that leave you with?
Less blood flow to your lung.
Less blood flow to the lungs, exactly, okay? So diminished blood flow to the lung because it can't get into the pulmonary artery. And if it can't get into the pulmonary artery, what does that cause besides hypoxia? How about on the right side of the heart?
Right side heart failure.
Right-sided heart failure, right? Because you're going to get a backup of pressure in the heart because it can't get the blood out. And so you get like hypertrophy in the right ventricles and all that wonderful stuff because it's working real hard. You'll have a murmur, you have an ejection click, where you'll actually hear a click as it tries to overcome the artery. And these kids will get dyspnea, cyanosis. Now, coarctation of the aorta. What is a coarctation of the aorta? Great, so what does that mean?
It's small.
It's small, okay? So we have that's a little spot of the aorta that's pinched off, okay? So if you have a pinched off aorta, what are you gonna get on the left side of the left side of the aorta? The part that goes to the left arm and to the abdomen. Decreased blood flow, right? And what are you gonna get on the right side of the aorta?
Increased blood flow.
Exactly, increased blood flow. So you have increased blood flow, what does that do to the heart?
Makes it work harder.
Makes it work harder, makes it hypertrophy, makes it back up, makes congestive heart failure, right? May or may not hear a murmur. And the biggest thing that you notice is a difference in the blood pressures between the right and left arms. Okay? Which arm would have a higher blood pressure? The right arm or left arm?
Right arm.
The right arm would have a higher blood pressure. And the left arm would have a low blood pressure. Why would the left arm have a low blood pressure?
Because it's not getting blood.
Right, because there's a constriction that's blocking blood from flowing to the rest of the body. So the left arm has a low blood pressure and the right arm has a high blood pressure because we're overcoming resistance on this side across the aorta. If you remember, our aorta has 4 blood vessels in it, right? Comes off the heart. There's the blood vessel to the right arm, blood vessels to the head, 2 in the middle, and then a blood vessel to the left arm. And so if the aorta, if the constriction is somewhere in here, you're going to see a difference between the right side and the left side. Neat, eh?
Hey. You Canadian?
Something like that. What'd I do? There we go. All right. Cyanotic congenital heart defect. This is where they start to get kind of crazy. Okay? Now we're getting some really interesting defects. Elizabeth wanted me to mention, she wanted to brag, she has seen every single one of these. As a NICU nurse, she has seen every single congestive, every single heart defect in this book. That's pretty darn impressive there. So she's really good. I wish I had her teaching this
Lisa,
class.
you should have come talk.
I try, she won't do it.
Why not? Why not? We're nice people. Right. We don't judge.
Yeah, you do. But you guys judge all day. That's why I won't get on your Facebook page. I'm like, no, I'm not going to be part of that. Anyway,
Oh, no, I wouldn't put it on there. No offense, but
what's that?
you're not allowed on there. No offense, but
Yeah, no.
teachers aren't allowed on there.
And wisely so. Yep. Every once in a while, I want to tag you guys in something like, tag the Methodist senior nursing students. Like, did you guys see that wonderful article I posted yesterday about the gut?
Yeah, you did.
That was mind-blowing. I'm like, common sense, but holy cow. That blows my mind, the idea that the gut flora could be responsible for why. From the basics, it's, the gut flora is responsible for how you're going to respond to glucose. Sure. But that helps explain why some people have these really powerful dietary restrictions like celiac disease and they can't eat anything, whereas other people with celiac disease, they can eat some things, and other people with celiac disease, they can eat anything they want. Or why some people with gallbladder can't have, with a gallbladder taken out, can't have any fat at all, while others have no gastric upset at all with a high-fat diet. Because the gut flora is different. and each bacteria plays a part. I thought, wow, that's standing on the cusp of an amazing discovery here to come in the next, like we have to rewrite all of our nutrition textbooks in the next 5 years because of that discovery. That was pretty impressive. Anyway, so I wanted to tag you guys and I couldn't, but that's okay. So, tricuspid atresia.
You could just tag one of us and then put it on.
There you go. So it's caused by a malformation of the tricuspid valve. Children born with tricuspid atresia tend to also have other problems. Atrial septal defect, ventral septal defect, ductal arteriosus, that kind of stuff. The signs are often dramatic as the PDA starts to close. And why are the signs dramatic as the PDA starts to close?
Because now there's no pressure on the valve.
Okay. So the tricuspid valve is which valve again?
In between the right and
This one.
atrium.
The one on the right side of the heart, between the right and left atria? Okay?
No, between the right atria and the right.
I'm sorry, right atria and right ventricle, that's right. So the right-sided heart between the right atria and the right ventricle. So if there's a malformation of that blood vessel, of that valve, and it's not allowing blood to flow through, where is blood flowing through? Through the foraminal valley, and then through the ductus arteriosus. So as the ductus arteriosus starts to shut down, all of a sudden we lose. As we start to lose fetal circulation, we'll lose blood flow to our right ventricle. And if we lose blood flow to our right ventricle, then where do we lose blood flow to? The lungs, right? And so if no blood's going to the lungs, and we close our ductus arteriosus, we're getting no oxygenated blood traveling through the body, okay? And so these kids start to have a dramatic decompensation as the PDA starts to close. We get a pansystolic murmur at the left sternal border. And so you got a kid who's all of a sudden turning blue for no good reason. You listen to his heart. It's making all kinds of crazy railroad sounds. And you go, holy cow, that's not good. And this kid might have a tricuspid atresia. Okay? By the way, what do you think you would do for the tricuspid atresia if this kid was, this is not exactly a nursing thing, but it's an interesting thing. We ask a quiz question about this. So as he starts to shift from fetal circulation to newborn circulation or adult circulation, he starts to decompensate because his ductus arteriosus is closing. And what do you think the doctor's going to do as an emergency thing? How about keeping the ductus arteriosus open, right?
Right.
And what can he do to keep the ductus arteriosus open?
Reposition.
No?
And he's gonna give him
It's going to give him what?
NSAID.
It's going to give him an NSAID, exactly, to block the prostaglandins and keep the ductus arteriosus open. They usually give indomethacin because it's a wonderful IV, powerful NSAID that they can use. Neat, eh? Eh?
Have you ever seen Brother Bear or whatever?
Oh, sure.
You know the moose?
Yeah.
That's what you remind me of.
Nice. Thanks.
Just well, you know how he says A all the time?
Yeah.
Like, A?
Yes. And of course, those two are a spoof on Daryl and my brother Daryl from, was it Bob Newhart show?
Yeah.
The Bob Newhart show. You're
They don't
too
know
young
what
for
you're
that,
talking
never
about.
mind.
They have no
They are, you guys know.
I know the Brady Bunches.
Nice. Newhart was before the Brady Bunch.
This is my brother Daryl, my other brother Daryl.
Yeah, this is my brother Daryl, my other brother Daryl, exactly. They crack me up. But that's who those mooses are, is Daryl and Daryl. Anyway.
The niece?
The meese, the mooses, the meese. So, total anomalous pulmonary venous return. Ooh, that sounds bad. What do you think total anomalous pulmonary venous return is?
Well,
Ooh.
it's how it does.
It's where the pulmonary blood flow returns to the heart through the right atrium rather than the left.
I would say that would be bad.
That would be bad.
I think that would be bad.
Yeah, when you've got the blood flow going in the wrong direction, right? If you've got blood flowing from the oxygenated blood flowing from the lungs and going to the right side of the heart, going back to the lungs again, right? You end up with a circle. And if you have a circle of blood going from the lungs back to the lungs, from the lungs to the heart, back to the lungs again, you're not getting blood into the left ventricle, and you're not getting blood to the aorta. And if you're not getting blood to the ventricle and the aorta, you got a little problem, right? So you're going to get another murmur, and you're going to get cyanosis, respiratory distress, and lethargy. How wonderful.
Oh, and
All the typical signs of cyanosis and respiratory failure are there. And we do our standard tests. Considering the fact that all the side effects are pretty much the same, and considering the fact that all the diagnostic tests are pretty much the same, can you see where the only value here is understanding what each congenital heart defect is, so you can explain it? Okay? To know that a total anomalous venous return, a pulmonary venous return means that blood flow is flowing from the lungs back to the atria, back to the right atria instead of to the left atria. That's the most important part. Okay? This is where we start to get really funky.
This is not good.
These are really bad.
Can we take a pee break?
Pee break already? What time is
Well,
it?
I don't wanna miss this and I really have to.
Okay, then fine, we'll stop. She's,
I don't wanna be rude here and get up. I feel bad when I do that.
don't worry, we'll just all sit and wait for you.
No pressure.
No. Guys, go take a break, because I'm not going to break after this. We'll come back at 3.
Okay.
Okay.
Everybody else pee too, so we'll have to do this
So
again.
nobody else has to pee?
That's right.